Hello and welcome to Learn OBGYN. This is Amir. Today's video will be covering ectopic pregnancies. Let's start off with a little background. The rate of ectopic pregnancies include about 2% of all reported pregnancies. So this is not an uncommon condition. Despite being 2% of all pregnancies, it causes about 2.7% of all pregnancy-related mortalities. In fact, it is the leading cause of hemorrhagic-related mortality. This is why it's such an important topic for not only OBGYNs, but any kind of provider who will deal with pregnant patients. In fact, some studies report that up to 18% of patients who come to the ED with first trimester either vaginal bleeding and or abdominal pain actually have an ectopic. Because of such a high incidence and also high mortality rate, it is very important to have a low threshold and always be suspicious for this diagnosis. So what is an ectopic pregnancy? An ectopic pregnancy is any pregnancy that occurs outside of the uterine cavity. The most common location for an ectopic is the fallopian tube. This is a high-yield fact for both your exams and a potential pimping question as well. To be more specific, the ampulla is the most common location of the fallopian tube for an ectopic to occur at. Let's take a moment to review fallopian tube anatomy and exactly where the ampulla is. The fallopian tube can be divided into 5 sections. You have the outer sections, which are right here, and these are called the fimbria. Then the next section is this sort of tunneling area, and that's called the infundibulum. That is then followed by the ampulla. Then you have the isthmus. And then you could also include a small section which is located inside the uterus itself, and this is known as the intramural portion. So to repeat, you have the fimbriae, infundibulum, the ampulla, and remember ampulla is where most of the ectopics will be seen, then the isthmus, followed by the intramural portion of the fallopian tube. However, as we said, an ectopic pregnancy is any pregnancy that occurs outside of the uterine cavity. So this could include also the abdomen, the cervix, ovary, and can even occur at the site of a previous C-section. The next word I'd like to define is a heterotopic. A heterotopic pregnancy is a pregnancy in which you have both a ectopic and an intrauterine pregnancy. So basically you have 2 pregnancies at the same time. One is in the correct location and one is located somewhere outside the uterus. This is a relatively rare occurrence, and in naturally occurring pregnancies, it occurs somewhere between 1 in 4,000 to 1 in 30,000. But in someone who had artificial reproductive technology to assist with a pregnancy, some studies report this as high as 1 in 100. And lastly, a pregnancy of unknown location. This is not quite a definitive diagnosis, but more of a transient state when we do not know where the pregnancy is located. Anyone who is pregnant and who does not have an ultrasound-confirmed intrauterine pregnancy basically has a pregnancy of unknown location. Most of the time, we can assume it's in the uterus, but if someone presents with vaginal bleeding or abdominal pain, especially in the first trimester, you should be suspicious that this pregnancy of unknown location may actually be an ectopic pregnancy. What puts a patient at an increased risk of having an ectopic? Like basically any other OBGYN condition, you could say a history of that previous condition in the past is a risk factor. If someone has had one ectopic pregnancy, they have about a 10% chance of having a repeat ectopic. If they've had 2 ectopic pregnancies or more, they have about a 1 in 4 chance of having a repeat ectopic. You don't have to memorize these statistics. They're just here to sort of emphasize how a history of this condition puts them at increased risk in the future. If a patient has some sort of fallopian tube damage, any sorts of adhesions, such as from either a pelvic infection like PID or a history of pelvic surgery, they're at increased risk of having adhesions that may inhibit the fertilized egg from reaching the target of inside the uterus, leading to an ectopic. As we said, IVF, or actually any kind of assisted reproductive technology, can increase the risk. Infertility by itself, even if someone does not undergo IVF, is a risk factor. One way to think about this is a potential source of infertility is having fallopian tube damage, so this infertility may actually be representing more of an issue from this source over here. Cigarette smoking and AMA. Remember, AMA stands for Advanced Maternal Age, and that's anyone equal to or greater 35 years old. Knowing these risk factors are important both for your exam and also for taking care of your patient. But keep in mind that about 1/2 or 50% of all patients will not have any risk factors when they present with an ectopic. So do not remove this from your differential just because the patient does not have any known risk factors. Is having an IUD a risk factor? This sometimes is a little confusing because of how statistics work, but if a patient has an IUD, they're less likely to become pregnant. The risk of becoming pregnant with an IUD is less than 1%. And if someone has fewer pregnancies, then they have fewer ectopics. So in general, having an IUD will reduce your risk of having an ectopic. That being said, if a patient is pregnant and they have an IUD in place, about half the time, or 53%, those pregnancies will actually be an ectopic. This figure on the right may help explain this a little bit. So on the left column, we have pregnancies that occur without birth control, and on the right side, we have pregnancies that occur with IUD. So as you can see, on the left side, there's much more pregnancies, and because of this, there are a lot more ectopics on this side, even though it's a smaller fraction of the entire number of pregnancies. Compared to the right side, there are fewer pregnancies, but out of those pregnancies, about half of them are ectopics. So again, IUDs decrease the risk of having an ectopic, but if a patient is pregnant and has an IUD, they have about a 50% chance of having an ectopic. So how does a patient with an ectopic present? They'll be pregnant, and they could present with a variety of symptoms, including vaginal bleeding. The vaginal bleeding may vary in terms of volume and pattern. It could be as small as spotting, or it could be much heavier. They may also have abdominal pain. Usually the pain is located in the pelvis, but this could be a diffuse pain. Diffuse pain, especially if they have signs like guarding, rigidity, or rebound, are very concerning for rupture of the ectopic pregnancy, which is a true obstetric emergency. On your pelvic exam, you may be able to appreciate a palpable adnexal mass which is consistent with the ectopic pregnancy. And in worst case scenarios, you may also see hemodynamic instability, indicating that rupture has occurred and the patient is no longer able to tolerate this. This could be represented with either hypotension, tachycardia, syncope, or altered mental status. But not all patients with ectopics have symptoms, and many also could be asymptomatic. Remember, about 18% of patients who come in with pregnancy in the first trimester, vaginal bleeding, and abdominal pain will have an ectopic. But what's the remaining 80%? Things to include in your differential include intrauterine pregnancy. So this could include a threatened abortion, which is a combination of vaginal bleeding and a still viable intrauterine pregnancy. It could be an incomplete abortion where the abortion has started but not yet completed, or the patient may have passed all products for conception already if she had a complete abortion. For more details about the different kinds of abortions, please watch my separate video on therapeutic and spontaneous abortions. The other key thing to always keep on a differential, ectopic pregnancies, and as a subset, the rare but also possible heterotopic pregnancy. But just because a patient is pregnant doesn't mean that her complaint is always due to her pregnancy. There may be other OBGYN problems such as ovarian torsion, pelvic inflammatory disease, or tubo-ovarian abscess, or it could be a completely non-obstetric issue, for example, appendicitis. Now let's talk about the evaluation and management of a suspected ectopic pregnancy. On the right side of the screen, you'll see the complete flow chart for entire evaluation and management, but what we'll do is we'll go through this chart piece by piece to make this more manageable and easier to understand. So let's begin with this section here, the initial evaluation, physical exam, and labs. So during your evaluation for someone with suspected ectopic, if you ever see these red flags, hemodynamic instability, or surgical abdomen, remember that's guarding, rigidity, or rebound, then at that time, you can no longer undergo expected management and you should consider proceeding immediately to surgery. This includes both your initial evaluation or at any time during the management. For example, if you decide to treat someone with methotrexate and all of a sudden they start complaining of great abdominal pain, or if you see they have hypotension and are bleeding heavily, then you can no longer proceed with expectant management or medical management and should proceed with emergent surgery. During your physical exam, It's also important to rule out a miscarriage, so you could do a speculum exam and you could potentially see products of conception either in the vaginal wall or at the cervical os. If you see this, you should collect this and send this off to pathology in order to get a tissue diagnosis and rule out the ectopic from your differential. When someone presents with a possible ectopic, you should be getting some labs. These labs include a quantitative HCG. A quantitative HCG is different than a qualitative HCG. A qualitative HCG will just say pregnant or not pregnant. But a quantitative HCG will give you a number, for example, 1500, and then that number could be used to trend the pregnancy to see if it's normal or abnormal. You want to get a CBC and a type 1 screen. The CBC can serve as both a baseline hemoglobin and hematocrit, and could also be one of the first signs of a dropping H&H secondary to bleeding from a ruptured ectopic in the abdomen. The type 1 screen is useful in case you have to give your patient a blood transfusion and need to cross and match for blood, or if the patient is Rh negative and you need to give RhoGAM to prevent Rh immunization. And then the other labs we get are AST, ALT, and creatinine. I also include the CBC one more time because all these labs are useful if you decide to give the patient methotrexate. We'll review why these labs are important for methotrexate in just a few slides. And then the next thing you want to do is ultrasound. A abdominal ultrasound may work, but transvaginal ultrasound is more specific and more accurate in determining whether a IUP or intrauterine pregnancy is present, or could potentially directly see an ectopic pregnancy in the adnexa or somewhere else that's not the uterus. Now let's talk about this section of the chart, or in more details about the ultrasound section. A transvaginal ultrasound is the diagnostic imaging of choice for an ectopic. In fact, if you ever get a question in your OBGYN board that says, what is the diagnostic imaging of choice for X condition, 99% of the time if you say transvaginal ultrasound, you will be correct. So with this ultrasound, you could potentially see an adnexal mass, and this can make you very suspicious for an ectopic. When diagnosed by transvaginal ultrasound, the diagnosis of ectopic has about an 80% positive predictive value. Other things that may also be confused for an ectopic that also occur by the adnexa include a peritubal cyst or a corpus luteum, hydrosalpinx, endometrioma if someone has endometriosis, or it could even be a loop of bowel. In order to have a diagnosis of an intrauterine pregnancy and basically rule out ectopic, you have to see one of the following. Either a combination of gestational sac and yolk sac, and this is very important that you know, it's a combination of these two. This is something that you may be tested on. You may have an answer choice where they just see a gestational sac and ask if this is an IUP, and the answer for that is no. In order to be a confirmed intrauterine pregnancy, you need both a gestational sac and a yolk sac. So that could be one possible way to diagnose an IUP, or you could see an embryo. By 5 to 6 weeks gestational age, if it is a normal pregnancy, you should be able to see one of those two inside the uterine cavity. Sometimes when a patient has twins, triplets, or higher order gestations, the HCG may be higher than what you'd expect. But even in cases of multiples, by 6 weeks gestational age, you should be able to see something inside the uterus if it actually is an intrauterine pregnancy. Let's talk more about HCG levels and move to this section of the flowchart. The discriminatory level is the HCG level where you expect to see an intrauterine pregnancy when looking with a transvaginal ultrasound. If you get an HCG quant that is above the discriminatory level and you do not see an IUP on transvaginal ultrasound, that means that you have a non-viable gestation. A non-viable gestation can either mean an ectopic pregnancy, a pregnancy inside the uterus that's abnormal, or possibly some sort of abortion. Either way, it represents something that will never go on to be a normal intrauterine pregnancy. In the cases where patients are pregnant and have HCG quants above the discriminatory level, about 50 to 70% of those patients will actually have an ectopic. So what is the cutoff for the discriminatory level? The most recent ACOG practice bulletin recommends 3,500. This is an important number to remember. In the past, this number used to be lower, sometimes as low as 1,500 to 2,000, but now this number has been moved up to a conservatively high number in order to prevent misdiagnosis. And what that means is you don't want to accidentally say, oh, I do not see a pregnancy at 2,000, then give someone methotrexate, and then have them come back a week later and then realize that it was actually an intrauterine pregnancy. By having this number higher will decrease your sensitivity but increase your specificity when you diagnose an ectopic. Now let's look at this section of the chart and learn what to do if your HCG quant is less than the discriminatory level. The HCG should increase and eventually plateaus once you get to above 100,000. But let's talk about how it increases before that point. The general rule of thumb, and this is something you definitely should know, is that HCG should double every 48 hours. For example, if you have a patient whose initial HCG quant is 1000 and you check it again in 2 days or 48 hours, it should be about 2000. That's a general rule of thumb, and as a med student, that's really what you're expected to know. But to be more specific, it doesn't necessarily have to double. In fact, it could increase as little as 33% over 2 days, and this all depends on what the starting HCG is. For example, if you start off over here with less than 1500, after 48 hours, you expect to increase at a minimum of 49%. If you're between 1500 to 3000, you expect to increase at a minimum of 40%, and anything above 3000, you expect to increase at least by 33%. As a med student, what I remember is generally HCG quant should double after 48 hours. And you could say at minimum, it should probably increase by 50%. When looking at normal pregnancies, they see that 99% of normal intrauterine pregnancies will increase faster than these minimums. So if you're increasing less than these minimum amounts, then you're very suspicious of having an abnormal pregnancy, whether it's abnormal intrauterine or abnormal as an ectopic. Now let's look at this section of the graph and review how to interpret HCGs after repeating them in 48 hours. There are 3 possibilities. Either the HCG could go down, it could raise appropriately, or it could raise inappropriately. If you have a decreasing HCG, this suggests a failing pregnancy. This could be a failing abnormal intrauterine pregnancy, an ectopic that's sort of being dissolved or reabsorbed into the body, or more likely it could be a miscarriage that recently occurred and completed. However, even though it's less likely to be an ectopic, it does not rule out an ectopic. Again, decreasing HCG is reassuring but does not rule out an ectopic. What you want to do is trend the HCG until it goes down to a non-pregnant level. So same thing right here, you're going to follow up the HCG, and usually you could do this weekly until you reach 0 or a non-pregnant level. If you have an appropriate rise, this is very reassuring for a normal intrauterine pregnancy, especially if you're increasing by the 2x limit every 48 hours. This does not rule out an ectopic or an abnormal intrauterine pregnancy, but it is very reassuring. So if you go down in this direction and you have an appropriate rise, the next thing you want to check is, are you now at the discriminatory level? If yes, you can proceed with ultrasound to see if there's an ectopic or intrauterine pregnancy. Or if your HCG is below the discriminatory level, you can follow along this path and repeat the HCG again in 48 hours. Again, remember, at any time during this management, if the patient becomes unstable or has a surgical abdomen concern for a ruptured ectopic, you must stop medical or expected management and proceed with surgery. The third option is if you have an inappropriate rise. If you have an inappropriate rise, it's very suspicious for an abnormal intrauterine pregnancy or even worse, an ectopic. If you have an inappropriate rise at this time, you should consider treatment. Treatment can either consist of a DNC, which is usually optional, and either methotrexate or surgery. A DNC, or dilation and curettage, is a form of uterine aspiration, and it is not necessarily the standard of care to proceed with this procedure when treating a suspected ectopic. The practice bulletin on this topic says it is something to consider, and you could do it after a discussion with the patient about the risks and benefits. So what are the benefits? You'll get more diagnostic information. After doing a DNC and getting the pathology from this procedure, you could determine for sure if there was an intrauterine pregnancy or not. By doing a DNC, you could potentially avoid laparoscopic surgery and avoid more invasive surgeries such as salpingectomy done for a potential ectopic. You may potentially avoid unnecessary methotrexate exposure. In general, we prefer to avoid giving medications that are not necessary, but in particular, methotrexate is actually a chemo medication, so if possible, we'd like to avoid this medication. And not only does it prevent potential exposure to the mom, but to the fetus if there's actually an intrauterine pregnancy. Also, with this additional information, you could potentially guide management of future pregnancies. For example, if someone actually had an intrauterine pregnancy, then this patient may be prone to having recurrent miscarriages, and you can start to manage that. Or if someone had an ectopic, you could be even more suspicious about this diagnosis in future pregnancies. The disadvantage of doing this is that it is an additional invasive procedure associated with additional costs, and it also may potentially delay treatment of an ectopic. By proceeding with a DNC, you have the delay of booking and waiting for a surgery date, and then also waiting for the results of pathology, which could take up to a few days. So in conclusion, a DNC is something you may do, but you don't have to do when evaluating an ectopic pregnancy, but it is more useful when the diagnosis is unclear. For example, when you're not able to visualize either an intrauterine pregnancy or an ectopic when looking with a transvaginal ultrasound. Once you're suspicious or once you've diagnosed an ectopic, the two main ways of managing it are either medical or surgical management. In order to be a candidate for medical management, the patient must be stable and there must be no contraindications. In general, if a patient is also a candidate for medical management, they usually can go with surgery as well, usually based off their preference. Methotrexate is a folate antagonist that is also used for chemotherapy for treatment of certain neoplastic diseases. It could also treat rheumatoid arthritis, psoriasis, and ectopic pregnancies. The mechanism, which is worth noting because you may be tested on, is it inhibits dihydrofolate reductase. This prevents the synthesis of purine nucleotides and amino acids. This affects all rapidly dividing cells, so this could affect the bone marrow, GI mucosa, and respiratory epithelium. It's also directly toxic to hepatocytes, and this medication is renally cleared. These three facts are important to remember because it can aid you in remembering the contraindications to methotrexate. These are the contraindications to methotrexate. It could be further divided into absolute contraindications or relative contraindications. This list is long, but if you break it down and think about it, it's actually very easy to memorize. You want to avoid methotrexate if there's a known IUP, because this is a teratogen. Immunodeficiency, anemia, leukopenia, and thrombocytopenia are contraindications, and you can remember this because methotrexate will affect the bone marrow. So if you affect the bone marrow, you'll have less of these progenitor cells, and you prefer to avoid exacerbating any condition in which you're already low on your white blood cells, red blood cells, or platelets. If the patient's sensitive or allergic to methotrexate, you obviously want to avoid giving methotrexate. Remember, methotrexate acts on the respiratory epithelium, so that's why you want to avoid if someone has active pulmonary disease. It is noteworthy that asthma is an exception, and you can give methotrexate if a patient has asthma. Peptic ulcer disease, because methotrexate affects rapidly dividing cells of the GI mucosa. Since methotrexate is toxic to hepatocytes, avoid if there's significant hepatocyte dysfunction. And since methotrexate is renally cleared, avoid if there's renal dysfunction. If the patient is breastfeeding, you want to avoid giving this because it could accumulate in breast milk. If someone is ruptured or hemodynamically unstable, you should consider these sort of together as one topic. You want to avoid medical or expectant management and should proceed with surgery instead. And if they're unable to participate in follow-up, you cannot give methotrexate because methotrexate is not 100% effective, and you have to make sure that they follow up to ensure that they received appropriate treatment. The relative contraindications include factors that make methotrexate less likely to be successful or risky to proceed with a non-surgical option. When you see cardiac activity of the embryo, this makes it less likely for methotrexate to be successful. If the initial HCG levels are high, and for high you could say anything above 5,000, this is less likely to be successful. There's about a 14% failure rate when HCG is above 5,000. You don't have to remember 14%, but I just bring this up so you understand why it's a relative contraindication instead of an absolute contraindication. If the pregnancy is large in size or greater than 4 centimeters, you want to avoid methotrexate because it becomes less likely to be successful. And also, if a patient refuses to accept blood transfusion, you do not want to be in a position where there's a ruptured ectopic and the patient's anemic and unfortunately cannot get blood because you proceed with methotrexate instead of surgery. Now let's review how we give methotrexate once we find a stable patient who has no contraindications. The first thing we have to do is get a CBC, type and screen, AST, ALT, and creatinine. Remember, we do this to make sure the patient has no anemias or any kind of bone marrow issues, as well as get a baseline to make sure they're not anemic, a type and screen to see if they need ROGAM, AST and ALT to make sure that they have no significant hepatocyte dysfunction because this is toxic to hepatocytes, and creatinine because this medication is renally cleared. This specific protocol on how medication is given is probably over the level that you need to know as a med student, so don't bother memorizing this, but just listen and enjoy for the sake of learning. You give methotrexate IM, and the dosage is based off their body surface area. It's body surface area times 50, and then additionally, depending on their RH status, if they're RH negative, you'll give them ROGAM. This is considered day 1. On day 4, you come back and you measure the HCG, and then you have them come back 3 days later on day 7. What you expect to see, if the medication is working appropriately, a drop in HCG of at least 15% from day 4 to day 17. If this is an appropriate drop, then you repeat HCG weekly until HCG hits 0 or non-pregnant levels. If it doesn't drop by at least 15%, then your 2 options are either repeat methotrexate and treat that repeat dose as your new day 1, or proceed with surgery. There are other protocols, such as a 2-dose method or fixed multiple dose method, but as a med student, I wouldn't worry about that, but instead, just focus on knowing which labs you need. And also, it's worth remembering that you should expect to see a 15% drop between days 4 and day 7. After you give methotrexate, there are a few things you should counsel the patient on. First of all, and probably most importantly, are return precautions. If a patient has signs of rupture, such as abdominal pain, feeling dizzy or lightheaded, or worsening vaginal bleeding, they should call the office or present to the emergency department. Because methotrexate works by inhibiting dihydrofolate reductase, you want the patient to avoid prenatal vitamins which contain folate, and also other foods which are high in folate as well. NSAIDs can actually decrease the efficacy of methotrexate, so you want the patient to stop taking NSAIDs. You also want the patient to avoid narcotic pain medication and alcohol because these may decrease the pain associated with a ruptured ectopic, and patients may not realize what's going on. And for the opposite reason, you want to avoid gas-producing foods because you don't want the patient to have pain from gas symptoms and confuse that for a ruptured ectopic as well. Because methotrexate can cause methotrexate dermatitis, the patient should avoid sunlight as well. During the initial treatment, you want to avoid any new pregnancies because when trending the HCG, a new pregnancy may cause a false reason for an elevated HCG quant. Also, immediately after, in the first 1 to 3 months, the patient should avoid becoming pregnant because, as we know, methotrexate is a teratogen and it is not immediately cleared from the system. The FDA says it's safe to resume attempting pregnancy after 1 ovulatory cycle. However, other studies have shown that methotrexate is in the system longer, so the recommendation ranges between 1 to 3 months after receiving methotrexate. Now let's discuss surgical management for an ectopic pregnancy. So who can get surgical management? The key things to remember is if the patient is hemodynamically unstable with tachycardia or hypertension, or has evidence of a surgical abdomen that's rebound, guarding, or rigidity, or findings of a ruptured ectopic, these patients absolutely must have surgery. This is an emergent surgery, and the patient should be taken back to the OR immediately. If the patient has any absolute contraindication to methotrexate, then they should definitely have surgery as well, although it's not necessarily as emergent. And even a relative contraindication may be a good reason to proceed with surgery instead of methotrexate. And finally, it's important to note that if a patient desires surgery, even if they are a good candidate for methotrexate, it is reasonable to give them both the option of proceeding with either methotrexate or surgery after a discussion of the pros and cons of each method. When performing surgery, if the ectopic is located in the fallopian tube, which remember that's the most common location for ectopics to occur, in the ampulla of the fallopian tube, you could either perform a salpingectomy, or a salpingostomy. The difference is with a salpingectomy, you're removing an entire segment, usually the entire fallopian tube. But with a salpingostomy, a small incision is made, the pregnancy is removed, and then the tube is closed up again. The advantage of having a salpingostomy is that you still have both tubes when the surgery is completed, but a salpingectomy is faster and more likely to remove the entire ectopic pregnancy. Even though with a salpingostomy, you do retain both tubes, there are about the same rates of future pregnancies, intrauterine pregnancies to be more specific, and also same rate of ectopic pregnancies when you compare salpingectomies to salpingostomies. So despite the fact that one tube is removed with a salpingectomy, it does not seem to alter the rate of intrauterine pregnancies as long as a contralateral tube remains. That being said, a salpingostomy should be considered more if the contralateral tube is already gone or damaged from some other etiology. If you do a salpingostomy, because of increased risk of leaving some of the ectopic behind, it's important to continue to trend the HCG. That's if you do a salpingostomy. This is not necessary if you do a salpingectomy. This surgery can either be done minimally invasively with laparoscopic surgery or with laparotomy. Typically, laparoscopic surgery is preferred because of its faster and better recovery. Smaller incisions are also more cosmetically appealing to the patient as well. Laparotomy is typically reserved for a very hemodynamically unstable patient. That being said, because most surgeons are very fast with operating laparoscopically, laparoscopy can still be used if a patient is hemodynamically unstable, but for testing purposes, you should consider laparotomy if you see that the patient is hemodynamically unstable in the question stem. And don't forget, if the patient's Rh negative, they should be receiving RhoGAM to prevent Rh alloimmunization. Now let's do one final review on how to manage an ectopic pregnancy. So if a patient presents with a pregnancy of unknown location, vaginal bleeding, or abdominal pain, there is an 18% chance this is an ectopic. You should do a physical exam, make sure there's no surgical abdomen, and make sure the patient's not having a miscarriage, get a HCG quant in order to trend her HCG, CBC type and screen, and AST, ALT, creatinine to make sure she is a candidate for methotrexate. We will get an ultrasound, and the ultrasound will either show that the patient has an ectopic. Remember, there's an 80% positive prediction value for ectopic seen on ultrasound, and if that's the case, you can proceed with surgery or medical management as long as the patient is hemodynamically stable. It's always important to remember, anytime during evaluation, if a patient is unstable or has a surgical abdomen, you can no longer wait and do expectant management or medical management and must proceed with surgery. The other alternative of an ultrasound is to see IUP or intrauterine pregnancy, and at that point you can stop because this is no longer an ectopic. Or more commonly, on your question stem, you'll continue to see nothing in the uterus and nothing in the nexa, and you'll have a pregnancy of unknown location. At this point, you look at the HCG level to see if it's above the discriminatory level. The current recommendations for discriminatory level are 3,500. In the past, it was a lower number such as 2,000, but now we're using 3,500 in order to avoid misdiagnosing an intrauterine pregnancy as an ectopic. If the HCG level is below this, then what we'll do is repeat the HCG in 2 days or 48 hours, and we expect it to double, but really the minimum we expect it to go up is about 40%. If there's a decrease in the HCG, most likely this is a miscarriage or an abnormal intrauterine pregnancy or ectopic that's being reabsorbed, but this does not rule out an ectopic, and because of this, you have to trend the HCG until you reach 0. If there is a rise, but it's an inappropriate rise, then it makes you very suspicious for either an ectopic or an abnormal intrauterine pregnancy, and at that point you should proceed with treatment. You can or cannot do a DNC if you want to get more information. Otherwise, you should proceed with either medical management with methotrexate or surgery. If there is an appropriate rise in HCG, you continue trending your HCG until it's more than a discriminatory level, and then you repeat an ultrasound. At this point, you'll either get the diagnosis of ectopic intrauterine pregnancy, or you'll be back at this square here, where it's either an ectopic or an abnormal intrauterine pregnancy, and then again, you should proceed with surgery or methotrexate. Hopefully by now you have a good understanding of everything in this chart, and you'll be able to answer the 1 or 2 questions you'll definitely get on your shelf exam regarding ectopic pregnancies. If there are any errors in the slide, I will post them in this section over here. And finally, if you're interested in additional reading, I recommend reading the practice bulletin on ectopic pregnancies. This is practice bulletin 193. That's all for this video. I hope you have a wonderful day.